For most of my career, I have been confidently, consistently, and completely wrong about where facial aging begins, and the correction came not from a dermatology conference or a cosmetic surgery journal, but from a patient's hip on an unremarkable Tuesday afternoon in November that I almost forgot by Wednesday. She was 62, came in for lower back pain that had been grinding at her for 8 months, the kind that sharpens when she stands up from her desk and fades after 10 minutes of walking, but never fully disappears. And when I examined her hip rotation, specifically the external rotation on her left side, it was almost gone, locked. The femur would not rotate outward past 10 degrees. The right side moved freely, a smooth 45 degrees of painless rotation, completely normal for a 62-year-old woman who walks 3 times a week. Unremarkable visit, except for one detail I almost didn't register because I was focused on her lumbar spine and the referral she wanted for an MRI. The left side of her face sat lower than the right. Not dramatically, 3, maybe 4 millimeters. The kind of asymmetry you'd chalk up to sleeping position, genetics, the general drift of soft tissue over 6 decades of gravity and expression in life. But her chart told a different story. She had photographs taken 18 months earlier for a completely unrelated issue, and in those photos, her face was symmetric. The descent on the left side, the slight deepening of the nasolabial fold, the softening of the jawline contour, the subtle inferior migration of the malar prominence had progressed over the same 18-month window during which her left hip had stiffened. Coincidence is a comfortable word. I leaned on it for the first 3 patients who presented this pairing. By the 5th, I started a notebook. By the 10th, the notebook had turned into a spreadsheet. By the 30th patient, coincidence had become a word I could no longer use honestly, because the pattern was too specific, too lateralized, too stubbornly consistent to be explained by chance or confirmation bias, or the very human tendency to find patterns in random noise. The patients with the most restricted hip external rotation showed the most pronounced facial tissue descent, and the descent was on the same side as the restriction. Not both sides equally, not randomly distributed. Left hip tight, left face lower. Right hip tight, right face lower. A correspondence that made no sense within any anatomical framework I had been taught, because my training separated the hip and the face into distinct clinical territories governed by different specialists, connected by 3 feet of trunk and neck and muscle and bone that supposedly had nothing to say to each other. And the hip twist, a 60-second positional release I was prescribing for their lumbar complaints, a Psoas targeted mobilization that has lived quietly in the manual therapy toolkit for decades. Unremarkable, unglamorous. The kind of thing you prescribe and forget about, was producing changes in their facial tissue that I had no clinical framework for predicting or explaining. Patients would return for their follow-up, and the tight side of their jaw would feel softer under palpation. The mid-face on the restricted side would sit slightly higher, 1 millimeter, sometimes 2. I began measuring it formally in a subset of 28 patients using standardized facial photography, identical lighting, identical head position, identical camera distance. And the photographic measurements confirmed what my hands had been telling me for months. Something was connecting these structures across a distance that the anatomy textbooks on my shelf treated as irrelevant. This is the point where a more disciplined clinician would have designed a study and submitted a paper. Instead, I did something that has no place in the research protocol, but that turned out to be more illuminating than any controlled trial could have been. I started looking sideways, at populations, at cultures, at the way different civilizations have positioned their hips for thousands of years. And what I found rearranged my understanding of how the human body communicates with itself in ways that I am still processing. There is a neighborhood in Kyoto, not a clinic, not a research institute, not a university, just a residential neighborhood near the Philosopher's Path. Quiet streets lined with wooden houses where elderly residents still sit on tatami, and where the rhythms of daily life have not fully surrendered to the plastic chair and the upholstered sofa. I spent time there, observing a community of men and women in their 70s and 80s who still practice daily Seiza sitting. Seiza is the formal Japanese kneeling posture. Shins flat against the floor, weight resting on the heels, hips in deep flexion, but with the femurs rotated into a position that allows the pelvis to settle between the feet. It is the posture that has anchored domestic Japanese life for centuries. The position for tea ceremony, for meals, for conversation, for prayer. It is not a stretch or an exercise. It is simply how these people sit when they are at home, how they have sat since childhood, how their parents sat before them. And what it does to the hip is remarkable. The position cycles the femur through a combination of deep flexion, moderate external rotation, and adduction that maintains the length and slide capacity of the deep hip musculature with a specificity that no gym exercise replicates. The psoas, the iliacus, the obturator internus, the gemelli, tissues that shorten and stiffen in a chair over decades, remain at their functional length in a body that spends significant daily time in Seiza. These elderly residents in Kyoto had facial tissue patterns that were measurably different from anything I had documented in my Western clinical practice, and different in a specific, anatomically coherent way. These were not young faces. They were not unwrinkled faces. They were faces that carried 8 decades of sun and weather and expression and emotion. But the tissue sat differently on the underlying bone. The midface maintained its vertical position relative to the orbital rim. The malar fat pads, the triangular fat compartments that give the upper cheeks their volume and contour, stayed in their anatomical home rather than descending toward the nasolabial fold, which is the characteristic pattern of mid-face aging in Western populations after 60. The jawline preserved a definition, a sharpness of the mandibular border that in my clinic, patients of the same age had long since softened into the early architecture of jowling, that blurring of the chin to neck transition that Westerners accept as an inevitable feature of aging past 60. And the left-right asymmetry that I had been documenting obsessively in my own patients was almost entirely absent. Both sides of the face descended at the same gentle rate, in the same subtle pattern, because both hips had maintained the same range of motion across a lifetime of symmetric floor sitting. There was no dominant side restriction, no decades of crossing the right leg over the left in an office chair, no 40-year habit of driving with the right foot fixed on a pedal while the left hip sat idle in flexion. The loading was bilateral, the mobility was bilateral, and the facial aging was bilateral. Symmetric input produced symmetric output across an anatomical distance that my medical education said should not transmit anything at all. Floor-sitting cultures do something to the hip joint that no chair, regardless of how thoughtfully it is engineered, can replicate. The position cycles the femur through ranges of rotation, flexion, and adduction that maintain the fascial slide between tissue layers, the capacity of adjacent fascial planes to glide independently over each other, which is the mechanical prerequisite for joint mobility, in which is the first thing lost when a joint is held static under sustained load. A modern office chair holds the hip at approximately 90 degrees of flexion with near zero rotation for 8 hours a day, 5 days a week across a 40-year career. Under those conditions, the psoas shortens. The fascial layers surrounding it lose their independent glide. Crosslinks form between adjacent collagen sheets, binding them into a single stiff mass where there should be 2 mobile surfaces. Fascia is not a passive wrapping. It is a living, adaptive tissue that remodels itself continuously along lines of sustained mechanical stress. And the stress of a chair tells the hip fascia to become short, stiff, and bound. The consequences of that remodeling do not stay at the hip. They travel upward through a continuous fascial pathway that anatomists have described in meticulous detail, but that clinicians have, with striking consistency, treated as anatomical trivia rather than clinical reality. I started pursuing this pattern across every population I could access, through clinical observation of patients from different backgrounds, through professional travel, through the published ethnographic, anthropological, and movement science literature. The next significant data point arrived from a colleague practicing in Mumbai, who had been tracking her own version of the same observation without knowing I existed. She had noticed the same absence of facial asymmetry and the same preservation of mid-face architecture in patients who had maintained lifelong yoga practices emphasizing hip-opening postures. The Indian yogic tradition has devoted extraordinary attention to hip mobility for at least 2,000 years, with a specificity, a patience, and a systematic sophistication that Western exercise science has only recently begun to take seriously. Padmasana, Baddha Konasana, Agni Stambhasana, Ekapada Rajakapotasana, Gomukhasana, these are not the flexibility parlor tricks that Instagram sometimes reduces them to. They are sustained positional holds, maintained for minutes at a time, practiced daily across decades, that cycle the hip through external rotation, abduction, and flexion with deliberate, graduated, patient loading of the deep anterior and lateral hip tissues. The holds are slow because the target tissue demands slowness. Fascia responds to sustained mechanical load over 30 seconds, 60 seconds, 2 minutes, timescales that muscular stretching considers absurdly long. The yogic tradition discovered this principle through millennia of empirical observation, through direct felt experience transmitted from teacher to student across 100 generations, without ever naming the tissue type, or the remodeling mechanism, or the collagen cross-link dynamics. They didn't need the vocabulary, they had the result. My colleagues' patients, women and men in their 60s and 70s with 40+ years of consistent daily practice, showed a facial tissue architecture that mirrored what I had seen in Kyoto. The mid-face held. The malar fat pads stayed in their anatomical position. The jawline maintained its mandibular border definition. The bilateral symmetry persisted into an age range where my Western patients routinely showed 3 to 5 millimeters of asymmetric descent. These were not patients selected for exceptional genetics or cosmetic intervention history. They were ordinary people whose extraordinary habit was hip mobility. Two populations, two cultures separated by 4,000 miles, by language, by religion, by cuisine, by climate, by genetic ancestry that diverged tens of thousands of years ago. Japanese cuisine and Indian cuisine share almost nothing in macronutrient composition, preparation philosophy, or ingredient selection. The humid, temperate climate of Kyoto has nothing in common with Mumbai's tropical monsoon heat. UV exposure profiles differ dramatically. Air quality, water mineral content, cultural attitudes toward aging and beauty, all different. The single measurable variable these populations shared was sustained, lifelong, symmetric hip external rotation, maintained through daily movement practices embedded so deeply in cultural life that the practitioners did not think of them as exercise at all. They were simply how life was lived. Then I found a third population, and the third point collapsed any remaining argument for coincidence. Capoeira practitioners in Salvador, Bahia, in northeastern Brazil. Capoeira is, and this description has always felt inadequate to what I've watched in the Rota, a martial art concealed inside a dance, or a dance smuggling combat inside music, or possibly a 400-year act of cultural resistance encoded in movement. Its origins are in the enslaved African communities of colonial Brazil, who embedded combat training inside dance and music to practice it openly under the eyes of Portuguese authorities who would have punished overt martial practice. The movement vocabulary is built around the ginga, a continuous swaying weight transfer that looks effortless and requires extraordinary hip mobility to execute. The ginga cycles the hips through rotation, flexion, extension, and lateral translation in rhythmic, continuous, multi-directional patterns that, if you stripped away the music and the cultural context and the beauty of the thing, would read as one of the most comprehensive hip mobilization protocols ever devised. Nobody designed it as therapy. It was designed for survival, and it survived. and its practitioners' hips reflect 400 years of biomechanical intelligence that no rehabilitation laboratory has improved upon. The mestres and contramestres I observed in Salvador, practitioners in their 50s and 60s, some in their early 70s, who had been training since childhood, showed the same facial tissue preservation that I had documented in Kyoto and that my colleague had measured in Mumbai. Mid-face position maintained, malar architecture intact, jawline contour preserved, bilateral symmetry present into ages where chair-bound populations show significant, visible, photographable asymmetric descent. A third continent, a third cultural tradition, a third genetic background, a third diet, a third climate, a third history, and the same result, correlated with the same biomechanical variable. 3 continents, 3 completely unrelated civilizations, 3 populations whose historical, genetic, dietary, and environmental circumstances share nothing measurable, except that their cultural practices kept their hips rotating freely through external rotation across a lifetime, and their faces aged with a structural integrity and a bilateral symmetry that chair-dependent, hip-locked populations do not maintain. The mosaic was assembled. The pattern was staring at me from 3 directions at once. But a pattern without a mechanism is a curiosity, not a clinical tool. I needed the anatomy, the specific, dissectable, verifiable chain of structures that could explain how a joint 3 feet below the jaw could determine how tissue on the face responds to gravity and time. Without that chain, the observation would remain a fascinating coincidence dressed in cultural anecdote. With it, it becomes an intervention. So here is the anatomy, stripped of all comparison, stripped of narrative, stripped of metaphor, presented as the sequential chain of named structures that it is. The psoas major originates from the transverse processes, the vertebral bodies, and the intervertebral discs of T12 through L5. 5 spinal segments spanning the junction between the thoracic and lumbar spine. It is a deep muscle positioned anterior to the quadratus lumborum and lateral to the lumbar vertebral bodies, inaccessible to surface palpation, hidden behind the abdominal organs and the peritoneal cavity. It descends through the iliac fossa, crosses the pelvic brim and the hip joint, and inserts via a strong tendon on the lesser trochanter of the femur. When the hip is held in sustained flexion and internal rotation, the position a modern chair enforces for the majority of waking hours, the psoas undergoes adaptive shortening. The sarcomeres lose resting length. The fascial envelope surrounding the muscle thickens and stiffens. The tissue remodels itself to match the position it occupies most frequently, because the fibroblasts within fascia respond to sustained mechanical load by depositing collagen along the vector of that load. This is well documented. The clinical consequences for lower back pain, anterior pelvic tilt, and hip impingement are widely taught in every physical therapy program in the world. What is not widely taught, what receives almost no attention in clinical education, is what happens above the psoas. The psoas shares a direct, continuous fascial connection with the respiratory diaphragm. The medial arcuate ligament, a thickened arc of fascia that bridges over the superior aspect of the psoas at the level of the first lumbar vertebra, is not a separate structure that merely sits near the psoas. It is a densification within a continuous fascial plane. The fascia of the psoas and the fascia of the diaphragm are one tissue, continuous, undivided, verifiable under the scalpel. When the psoas shortens, it increases resting tension on the medial arcuate ligament, which restricts the excursion of the ipsilateral hemidiaphragm. The diaphragm on that side cannot descend as fully during inhalation. Breathing becomes shallower on that side. The lower ribs on that side lose their capacity for lateral expansion. Carla Stecco's dissection work at the University of Padua documented this fascial continuity in cadaveric specimens with a precision that left no room for ambiguity. The plane is continuous, the force transmission is real, in the clinical consequence is a diaphragm that is partially tethered by a psoas that is shortened in a chair. The diaphragm's crura, the paired muscular pillars that anchor the diaphragm to the anterior surface of the upper lumbar vertebral bodies, have their own fascial story. Inferiorly, the crural fascia blends into the anterior longitudinal ligament of the spine. Superiorly, it transitions into the endothoracic fascia and then into the prevertebral fascia as it ascends past the thoracic outlet into the cervical region. The prevertebral fascia is a single, uninterrupted fascial sheet extending from the base of the skull to the coccyx, draped anterior to the vertebral column, posterior to the esophagus and the thorax, and the pharynx in the neck. It is one continuous tissue plane across the entire length of the torso and neck. Tension increase at the level of the diaphragmatic crura, driven by psoas shortening, propagates superiorly through this fascial plane with the directness of a pulled thread in a fabric, because that is precisely what the anatomy is, a fabric under tension. In the cervical region, the prevertebral fascia has direct structural connection to the deep cervical fascia, the investing layer that wraps the sternocleidomastoid, the scalene muscles, and the infrahyoid group. These are not loose anatomical associations or textbook approximations. They are fascial continuities, shared tissue planes where the boundary between one named structure's fascia and the next named structure's fascia does not exist in the living body, however neatly the textbook illustrations draw it. Thomas Myers mapped this continuity as part of what he termed the deep front line, a continuous myofascial meridian running from the inner arch of the foot, through the posterior tibialis, up through the adductors and pelvic floor, through the psoas, through the diaphragm, through the mediastinal connective tissue, through the prevertebral fascia, through the deep cervical fascia, and into the base of the skull. His mapping was performed through cadaveric dissection and has been supported by subsequent dissection work and by emerging ultrasound elastography studies, demonstrating measurable force transmission along the pathway he described. At the base of the skull, the deep cervical fascia blends with the periosteum of the temporal bone, the sphenoid, and the occipital bone. Periosteum is dense, innervated, vascularized connective tissue that is continuous with the deep fascia everywhere it meets bone. At the cranial vault, periosteum is continuous with the gallia aponeurotica, the fibrous sheet covering the top of the skull, and with the temporal fascia that overlies the temporalis muscle. The architecture of the face hangs from this framework. The soft tissues of the midface are anchored to the underlying bone and deep fascia through a system of retaining ligaments that have been mapped in surgical anatomy with considerable precision. The zygomatic retaining ligament, the masseteric cutaneous ligament, the mandibular retaining ligament, the platysma auricular ligament. Each of these ligaments originates from periosteum or deep fascia that is continuous with the ascending chain from the hip. When the psoas shortens in the hip, tension propagates upward through the medial arcuate ligament, through the diaphragmatic crura, through the prevertebral fascia, through the deep cervical fascia, into the cranial periosteum. This ascending tension creates a caudal vector, a sustained, gentle, persistent downward and inward pull on the periosteal anchors of the facial retaining ligaments. Under sustained caudal tension across months and years, the retaining ligaments elongate. Their periosteal attachment points migrate inferiorly in response to the chronic mechanical load. The malar fat pad, suspended by the zygomatic retaining ligament, descends. The nasolabial fold deepens as the descended fat pad compresses against the relatively fixed tissue of the upper lip. The jawline softens as the mandibular retaining ligament elongates and the buccal fat pad shifts downward and forward. And because psoas shortening is almost always asymmetric, most people have one hip significantly tighter than the other, shaped by decades of leg dominance, habitual cross-leg sitting, sleep posture, old injuries, and occupational loading patterns. The facial descent is asymmetric. One nasolabial fold deepens ahead of the other, One jowl forms first. One side of the jawline blurs while the other remains relatively defined. This is the pattern I documented across 30 patients, then 100, then several hundred. The anatomy explained the observation. The observation validated the anatomy. In both, together, explain the cultural patterns. Why populations that maintain symmetric, lifelong hip external rotation maintain symmetric facial tissue architecture, and why populations locked in chairs did not. This is not a speculative hypothesis. The anatomical continuity is dissectable, has been dissected, and has been published. Stecco's cadaveric work at the University of Padua confirmed uninterrupted fascial tissue planes, connecting these structures across the full distance from the psoas to the cranioperiosteum. The clinical observation that releasing hip external rotation produces measurable, photographable changes in facial tissue position within days is the predicted consequence of this documented anatomy. The mechanism explains the pattern. The pattern pointed to the mechanism. Understanding both reveals why this particular intervention works, and it also reveals something about the nature of the body's fascial system that makes the protocol more effective than simple mechanical stretching would predict. Tuning a stringed instrument and understanding how that instrument produces its tone are the same physical act. You cannot learn how the string generates a particular frequency without placing your fingers on the tuning peg and changing the tension. You cannot change the tension without hearing the tone respond. The learning is embedded in the doing. The doing generates the learning. They are not sequential, first understand, then act. They fold into each other, each pass deepening the other, recursive, converging. The fascial system works this way. The act of proprioceptively attending to a restriction, feeling where the hip is tight, noticing which direction the tissue resists, is itself the first phase of releasing that restriction. Conscious proprioceptive attention to a fascial line alters the resting neural tone of that line through intrafascial mechanoreceptors, the Ruffini endings and interstitial nerve endings that populate fascial tissue at densities that the research community, led by Robert Schleip's work, has only recently begun to catalog. Attending to the tension begins dissolving the tension. The observation is the intervention. The intervention deepens the observation. Each pass through this loop produces a deeper release than the last, which is why 60 seconds of conscious, attentive, proprioceptively engaged positioning achieves fascial changes that hours of passive, distracted stretching sometimes cannot. And the fascial network itself distributes tension across the body the way a decentralized computing architecture distributes processing load across a network. There is no central node, no master controller deciding where tension goes or how much each tissue bears. Instead, local fascial nodes, densifications, attachments, transition zones, communicate laterally through direct mechanical coupling, absorbing and transmitting force based on local tissue properties, stiffness, hydration, collagen density, the degree of cross-linking between adjacent fiber sheets. Understanding how this distributed architecture manages its load is itself an act of load redistribution, because the understanding changes which mechanical signals you attend to, and attending to different signals modifies the signals themselves through the proprioceptive fascial feedback loop. The knowing participates in the rebalancing. The rebalancing generates new knowing, recursive, convergent. This is why the protocol operates in 60 seconds, when passive stretching, which engages only the mechanical loading component and ignores the neurological proprioceptive component, sometimes requires months for comparable tissue change. Before the protocol, a diagnostic, not optional, not a formality. 3 assessments that determine which category of response you should expect, because the fascial chain is not active in every body to the same degree, and performing the intervention blindly without first establishing whether the chain is your relevant pathway wastes both your time and the protocol's credibility. First assessment, lie on your back on a firm surface, carpeted floor, yoga mat on hardwood, exercise mat on tile, any surface that is flat and does not compress under your weight. A mattress will not work. It absorbs the positional feedback your proprioceptive system needs. Bend both knees so your feet stand flat, hip-width apart, roughly 12 inches from your buttocks. From this position, let both knees fall outward simultaneously toward the floor, like a book opening at its spine. Do not assist the movement with your hands. Do not push, do not bounce. Let gravity alone determine where each knee stops. Observe the distance between each knee and the floor. If both knees descend to within roughly 1 fist width of each other, approximately the same distance from the floor on both sides, your hip external rotation is reasonably symmetric. If one knee drops significantly further than the other, a visible difference of 2 or more inches, note which side is tighter. The tighter side is the side where the ascending fascial chain is under greater sustained tension, and it is the side where fascial tissue descent will likely be more pronounced. Second assessment, remain on your back. Bring your right knee toward your chest, wrapping both hands around the shin or behind the thigh, and draw the thigh gently toward your abdomen until it makes contact. While holding this position, allow your left leg to extend fully along the floor, reaching the heel away from you, letting the entire posterior surface of the left thigh rest on the ground. Observe the left leg carefully. If the left thigh lifts off the floor even slightly, if the left knee bends involuntarily, or if you feel your lower back arching away from the floor to compensate, the psoas on the left side is shortened. It cannot tolerate the lengthened position that a fully extended leg demands while the opposite hip is in deep flexion. The lift, the bend, the arch, any of these compensations confirm psoas shortening on the extended side. Now switch. Left knee to chest, right leg extends. Compare the two sides. The side with more compensation, more lift, more reluctance to lie flat, that is the shorter psoas, the tighter link in the chain. Third assessment, stand up. Place the flat of your right hand against the right side of your jaw, fingers angled toward the ear, palm resting over the masseter muscle in the buccal fat pad just below the cheekbone. Mirror the position with the left hand on the left side. Press inward gently with equal bilateral pressure, about the force you would use to test whether a peach is ripe, firm enough to feel the tissue beneath, but not hard enough to cause discomfort. Attend to the quality of the tissue under each palm. Does one side feel denser, tighter, more resistant to gentle compression? Does one side feel as though there are more layers of tension between your palm and the bone underneath? In approximately 70% of the patients I have assessed who had unilateral hip restriction, the denser jaw side matched the tighter hip side. Right hip restricted, right jaw dense. Left hip restricted, left jaw dense. If this correspondence holds in your body, the chain is active, and the protocol directly addresses the mechanical pathway responsible for your facial tissue pattern. If both sides feel identical, and both hips tested symmetrically, the ascending fascial chain is likely not your dominant contributor, and the protocol will be a pleasant hip release without meaningful fascial effect. If your diagnostic revealed asymmetry, one hip tighter, one jaw correspondingly denser, the sides matching, here is the 60-second hip twist. Lie on your back on the same firm surface, knees bent, feet flat, hip width apart. Take the leg on the tighter side and cross that ankle over the opposite knee, placing a lateral malleolus, the bony prominence on the outer ankle, just above the opposite kneecap. Allow the crossed knee to fall outward under its own weight, opening the tight hip into external rotation with gravity as the only force. Do not push the knee with your hand. Do not bounce it toward the floor. Do not recruit muscular effort to increase the range. Let the weight of the leg, acting over seconds, determine how far the hip opens. You will feel a stretch deep in the hip, possibly in the lateral buttock near the piriformis, possibly along the inner thigh near the adductors, possibly deep in the anterior groin crease near the inguinal ligament. That sensation is the rotator complex and the psoas, responding to a positional demand they have been denied by years of chair sitting. Now the twist, which is the element that distinguishes this from every standard figure 4 stretch you have ever seen, in that targets the specific ascending fascial chain rather than the local hip musculature alone. Keeping the figure 4 position intact, ankle over knee, knee falling outward, gently rotate your entire lower body as a single unit toward the side of the crossed leg. The rotation originates in the lumbar spine. Your shoulders and upper back remain flat on the floor. The magnitude of the rotation is small, 10 to 15 degrees, no more. You are not trying to touch your crossed knee to the floor on that side. You are introducing a subtle rotational vector that changes the stretch from the external rotators into the deeper anterior compartment of the hip, the psoas itself, and the fascia that connects it to the diaphragm. You will feel the stretch quality shift. It migrates from the outer hip inward and forward toward the crease where the thigh meets the abdomen. That anterior depth is the psoas-specific component, and it is the entry point to the ascending chain. Hold this position for 60 seconds. During the hold, breathe into the lower ribs, not the upper chest. Place one hand on your lower rib cage if it helps you locate the expansion. Each inhalation should push the ribs outward, laterally, sideways, like an accordion opening. This is diaphragmatic breathing. In performing it while the psoas is in a lengthened and externally rotated position, mobilizes both anchor points of the psoas diaphragm fascial connection simultaneously. The psoas from below, the diaphragm from above. You are releasing the chain from two directions at once within a single held position, which is why 60 seconds here produces changes that 30 minutes of conventional hip stretching often cannot match. During the hold, attend to the sensations that emerge. Your breathing may deepen spontaneously, without conscious instruction, as the diaphragm gains excursion capacity from the reduced psoas tension on the medial arcuate ligament. You may feel a release that seems to travel up through the abdomen, into the lower rib cage, into the thoracolumbar junction, into the mid-back, into the base of the neck. Some patients report a spontaneous softening in the jaw within the first 30 seconds, a sensation of the masseter relaxing, the teeth unclenching, a subtle widening of the space between the upper and lower molars that they did not consciously initiate. This ascending release is the chain responding sequentially from the bottom up, and when you feel it, you are feeling direct proprioceptive evidence that the fascial pathway is real, continuous, and responsive to positional intervention at the hip. After 60 seconds, slowly unwind. Uncross the ankle. Lower the foot to the floor. Extend both legs flat along the surface. Lie still for 10 to 15 seconds. This interval is not filler. It allows the nervous system to integrate the new fascial resting length, to update the proprioceptive map that governs baseline muscle tone throughout the chain. Then repeat the third assessment, the jaw palpation. Both hands, same position, same gentle inward pressure. Compare what you feel now to what you felt before the twist. Most people in the asymmetric category notice that the previously denser side has softened. Not transformed, not dramatically lifted, softened. The quality of the tissue under the palm has changed. The asymmetry between the two sides has narrowed. Subtle, specific, and, if you take photographs before and after with consistent lighting and head position, measurable. For those whose diagnostic showed bilateral restriction, both hips tight and both jaws equally dense, perform the twist on each side. 60 seconds per side, beginning with whichever hip felt marginally tighter. The release will be bilateral, producing a general reduction in ascending fascial tension rather than a correction of left-right asymmetry. For those whose diagnostic showed mobile hips, symmetric rotation, and no jaw side differences, the ascending fascial chain is not your primary contributor to facial tissue descent. Your aging pattern is driven by a different pathway: ultraviolet collagen degradation, age-related fat pad volume reduction, a cervical or thoracic postural pattern that operates independently of the hip, or genetic variation in retaining ligament elasticity. The twist will not harm you, and many find it pleasant for its lumbar and hip benefits alone. but expecting significant facial tissue change would be unreasonable given your diagnostic profile. For those in the asymmetric group, frequency matters. The protocol that has produced the most consistent results across the patients I have followed is once daily, performed in the evening, ideally within an hour of going to bed. The evening timing is deliberate. The fascial system has been under compressive gravitational load throughout the day, accumulating stiffness and tension in the very patterns that the twist targets. End of day is when the system is most loaded and most responsive to positional release. The minimum duration for consistent observable results is 14 consecutive days. 14, not 4. Fascial tissue remodeling is not a muscular adaptation. It does not arrive in hours or overnight. It requires the fibroblasts within the fascial tissue to reorganize their collagen deposition patterns, to reduce cross-link density between adjacent fiber sheets, to restore hydration to the extracellular matrix. This biological remodeling operates on a timeline of weeks, not sessions. Most patients report noticeable facial tissue changes, confirmed by comparison photography and by palpation, between day 7 and day 14. A subset, roughly 20%, report perceivable softening within the first 3 sessions, and these tend to be the patients with the most severe unilateral restriction and the most pronounced facial asymmetry. A smaller group, approximately 15%, report no perceptible facial change after 3 weeks. Almost without exception, those are the patients whose diagnostic suggested the chain was not their primary pathway, reinforcing that the diagnostic step is not an optional introduction, but the clinical filter that separates appropriate candidates from inappropriate ones. This is a protocol for a specific subset of people. In determining whether you belong to that subset is the entire function of the diagnostic. If the 3 assessments revealed clear unilateral asymmetry, the protocol addresses the specific mechanical chain responsible for your specific pattern of descent. If the assessments did not reveal that pattern, this protocol is not your intervention. Knowing which category you belong to is not a limitation, it is the protocol's precision. There is something in all of this that exceeds the anatomy, exceeds the protocol, exceeds the clinical spreadsheet. 3 civilizations on 3 continents, separated by oceans and centuries and millennia of independent cultural evolution. Each created movement practices that maintained a specific joint range, hip external rotation. And each, without knowing it, without intending it, without having any framework for understanding the mechanism, was preserving a continuous fascial chain that maintained the architecture of the human face across decades. The Japanese did not codify Seiza to preserve their cheekbones. The Indian yogic tradition did not devote 2,000 years to hip opening asanas to prevent jawline descent. The Capoeiristas in Salvador did not create the jinga to maintain mid-face volume. Each tradition arose for its own reasons: ritual precision, spiritual practice, concealed combat, cultural identity, aesthetic beauty, and the facial preservation was a consequence that none of them anticipated or understood. An anatomical accident. A side effect of living in a body that connects everything to everything else through unbroken tissue, across distances that the medical tradition I was trained in spent centuries insisting were not real. What does it mean that a 60-second hip twist might do more for the architecture of the face than any intervention that touches the face itself? It means the body is not an assembly of independent regions serviced by independent specialties. It means the face is not an isolated canvas. It means the 3 feet between the hip and the jaw are not empty space occupied by unrelated structures. They are a continuous medium, conducting a mechanical conversation in the language of tension and load and fascial remodeling. And the conversation has been running your entire life, whether you were listening to it or not. The cultures that stayed on the floor, that kept moving through their hips, kept the conversation fluent and bilateral. The cultures that migrated to chairs and desks and cars let one end of the line go silent, and the silence climbed, vertebra by vertebra, through the trunk and the neck and into the periosteum, And the face recorded everything the hip stopped saying. And it means I was wrong. Wrong about where to look. Wrong about what to examine. Wrong about the distances that matter inside a body I thought I understood. The question that will not release me, the one I turn over at the end of every clinical day, is how many other lines are carrying conversations through the body right now, in fascial planes and mechanical meridians that nobody has yet thought to trace, because we have been so focused on the places where symptoms arrive that we forgot to follow the tissue back to where they begin.